Imagine this. You're sitting at home. Maybe it's a quiet evening. The television is on in the background, half watched. You take a sip of tea, glance at your phone, and then something doesn't feel right. Your face feels strange. You try to smile, but it doesn't quite move the way it should. Your arm feels different. Not painful, just not right. And then the room shifts. Not dramatically, but enough for you to notice. You pause. Your mind starts racing. Is this a stroke or am I overreacting? Because here's the uncomfortable truth. Even in hospital, among experienced clinicians, these situations are not always obvious. Stroke can look like something harmless, and something harmless can look exactly like a stroke. And getting that decision wrong, even by minutes, can change the rest of someone's life. I'm a UK internal medicine doctor, and today I want to do something different with you. I'm not just going to explain stroke symptoms. I'm going to test you. I'm going to walk you through real scenarios, situations I've seen in real patients. Each time, I want you to decide, stroke or not. Pause the video if you need to. Really think it through. Then I'll break it down, not just what the answer is, but how to think like a doctor in that moment. Because by the end of this video, you won't just recognize symptoms, you'll understand patterns, and that could genuinely save a life. Let's begin. Case 1. John is 58. He wakes up one morning feeling completely normal. He walks into the bathroom, flicks on the light, and looks in the mirror. At first, nothing seems wrong, but then he smiles. Only one side of his face moves. The other side just hangs there. He tries again, forcing the smile wider. Same result. His stomach drops. His heart starts pounding. Is this a stroke? So what do you think? Stroke or not? Take a second. This is one of the most frightening symptoms a person can experience. And in many cases, this is not a stroke. This is something called Bell's palsy, a condition where the facial nerve becomes inflamed, often quite suddenly. But here's where it gets really important. In a stroke affecting the face, the forehead is usually spared. That means the patient can still raise their eyebrows. They can wrinkle their forehead, even though the lower part of the face is weak. But in Bell's palsy, the entire side of the face is affected, forehead included. So if John tries to raise his eyebrows and one side doesn't move at all, that strongly points toward Bell's palsy rather than stroke. Now, this doesn't mean it's not serious. It still needs medical assessment. But the pattern is different, and this is your first key principle. Stroke tends to affect the lower face. Peripheral nerve problems affect the whole face. So remember this simple line. If the eyebrow still moves, think stroke. If the whole face is weak, think peripheral. Let's move on, because the next one is more subtle and often misinterpreted. Case 2. A 52-year-old woman is sitting quietly in her living room. She notices a faint tingling in her fingertips. It's not painful, just unusual. She flexes her fingers, shakes her hand slightly. But over the next few minutes, something happens. The tingling begins to spread, from her fingers into her hand, slowly moving up her arm. About 10 minutes later, her vision becomes slightly blurred, not completely gone, just not right. She starts to feel uneasy. Now you decide, stroke or not. This is a classic example where timing tells you everything, because this is much more likely to be a migraine aura, and the reason lies in how the symptoms evolve. Stroke is typically sudden. It reaches its peak immediately. One moment you're fine, the next, the symptom is fully there. But migraine behaves differently. It spreads. We call it a march. Symptoms move gradually across the body over minutes. Tingling that starts in one area and slowly progresses. That's very characteristic of migraine. Visual symptoms that follow, also common. In contrast, a stroke-affecting sensation tends to produce immediate numbness, not a spreading tingling. So here's the principle. Stroke hits like a lightning strike. Migraine creeps in like a wave. And once you recognize that pattern, it becomes much easier to distinguish the two. Now let's raise the stakes. Case 3. An elderly man is sitting at the dining table. Suddenly the room starts spinning. Not lightly, but violently. He grabs the edge of the table. His face turns pale. He feels intensely nauseated. He tries to stand, but he's unsteady, almost falling. His family rush to him. They're terrified. So what do you think? Stroke or not? This is where things become genuinely challenging, because this could be either. There is a very common condition called benign paroxysmal positional vertigo. It causes intense spinning sensations, what we call vertigo, and it can be dramatic. Patients often feel like the world is moving around them. They feel sick, sweaty, and distressed. But despite how severe it feels, most can still stand or walk, even if cautiously. Now compare that to a posterior circulation stroke. These strokes affect the balance centers in the brain, and when they occur, patients often lose the ability to coordinate movement. They can't walk properly. They stagger. They fall. They may not even be able to sit upright safely. So the key question is simple but powerful. Can they walk? If someone is so unsteady they cannot stand or take a few steps, that is a major red flag, and it should be treated as a stroke until proven otherwise, especially if there are additional clues. Double vision, slurred speech, difficult coordinating their hands. So remember this, severe dizziness alone is not enough, but dizziness plus inability to walk, that changes everything. Let's go even more subtle. Case 4. A woman stands up from her chair. Within seconds, she feels lightheaded. Her vision dims slightly, like a curtain briefly passing over her eyes. She grips the table. For a moment, she feels like she might faint. But then, just as quickly as it came, it disappears. Within 10 to 15 seconds, she feels completely normal again. So what do you think? Stroke or not? This is usually not a stroke. This is postural hypertension, a temporary drop in blood pressure when moving from sitting to standing. It's particularly common in older adults and in those on blood pressure medications. The key here is the pattern. It's triggered by standing, it comes on quickly, and it resolves quickly. Stroke does not behave like that. Stroke symptoms persist. They don't vanish within seconds. So here's the takeaway. If it's position dependent and short-lived, think blood pressure, not brain. Let's continue. Case 5. A man is standing in a queue at a shop. Without warning, he collapses. He loses consciousness. People around him panic. Someone calls for help. But within seconds, he begins to wake up. He's confused initially, but improving rapidly. Within a minute or two, he's talking. So what do you think? Stroke or not? This is a classic presentation of syncope, a faint, often related to a temporary drop in blood flow to the brain. And the key feature here is the loss of consciousness. In stroke, patients do not typically black out at the start. And if neurological symptoms are present, like weakness or speech problems, they persist. Syncope is different. It's brief, recovery is quick, and the brain returns to normal function rapidly. So here's a simple way to frame it. Blackout? Think heart or blood pressure. Ongoing neurological symptoms? Think brain. Now we come to the one that even experienced clinicians can miss. Case 6. A patient arrives at hospital. They feel dizzy. They feel nauseated. They are unsteady when they walk. But that's it. No facial droop, no arm weakness, no slurred speech, just dizziness. So what do you think? Stroke or not? This is where people get caught out. Because this can absolutely be a stroke, a posterior circulation stroke. And these strokes are dangerous precisely because they don't look typical. They don't follow the fast rules people are taught. No obvious weakness, no dramatic speech problems. Just vague symptoms that can easily be dismissed as something minor. And that's why I say this very clearly. The most dangerous strokes are the ones that don't look like strokes. So let's pause, because by now you've probably realized something. This isn't about memorizing a list. It's about understanding patterns. And this is exactly how doctors think at the bedside. Not just what symptoms are present, but how they behave over time. So let me give you something practical, a simple framework you can use in real life. The 4 stroke rules. If you remember nothing else from this video, remember this. Ask yourself, was it sudden? Did it reach its worst immediately? Is it affecting one side of the body? And is it still there? Sudden, maximal at onset, focal, persistent. If those 4 features are present, treat it as a stroke until proven otherwise. Because here's the reality. As a stroke doctor, I've seen what happens when people hesitate, when they wait, when they hope it will pass. And I've also seen the opposite. People who act quickly, who call for help early, who get treated in time. And the difference between those 2 paths is life-changing. So if you ever find yourself in that moment of uncertainty, or someone around you does, don't try to be certain. You don't need to be. If there's any doubt, treat it as a stroke and get help immediately. If this video has helped you think more clearly about stroke symptoms, then it's done exactly what it was meant to do, because most people won't prepare for this. But the ones who do are the ones who act in time. And that makes all the difference.